طيب, okay. Assalamu alaikum. Hello, everyone. My name is Abdulrahman Alabyad, and I'm a third-year medical student. And inshallah, today Khalid and I will be explaining the control of cardiac output lecture. I'll start with the first part, and if I was going a little fast throughout any of the parts, please let me know, and I'll start slow down. And if you had any questions, please feel free to stop me when I'm done with the slide, and I can explain it again to you. And with that being said, we can begin our lecture today. Now, when we're talking about controlling the cardiac output, what exactly we're going to be discussing is the main things that are going to be coming out with this cardiac output. So the cardiac output is going to contribute to the blood pressure. And so that's going to be the first thing that we're going to be talking about. And then the second thing that is going to be controlled by the cardiac output is the blood flow. So we'll also discuss that. And the last part is how exactly we're going to be plotting it and putting it in a graph, and that will be done by Khalid in the other part. So I'll be discussing the first two parts, the pressure and the blood flow. So with that being said, we can begin with the blood pressure, right? Now, when talking about the blood pressure, there is one main equation that I want you guys to remember. Mean arterial pressure is equal to the cardiac output times the systemic vascular resistance. Have you guys taken this equation before?
Yes.
Okay, so whenever we talk about cardiovascular physiology, use this equation as your reference with everything, okay? Because basically, like, if you get any physiology question, no matter like how complicated it might get, as long as it's related to blood pressure, you can solve it with this equation and understanding this equation. So let's say, for example, now before we go to that, let's try to understand. Okay. Wait. All right, so sorry about that. Now, so the cardiac output is going to be controlled by two main things, the heart rate and the stroke volume. The heart rate is basically how fast the heart is beating, and the stroke volume is how much blood is going out with every beat. And together, they give us the cardiac output, which just represents how much blood is coming out of the heart, or the output from the cardiac or the heart. The other one is the resistance. Now, the resistance talks about the vessels. So now the blood pressure is the pressure in the vessels. So we got two things contributing, what's coming out of the heart or what's inside the vessels, and then the pressure of the vessels. If the vessel is dilated, do you think it would have a higher or a lower pressure? If the vessel is dilated, it will have a lower pressure. And if the vessel is constricted, that will give the opposite effect, which is going to be a higher pressure. So if you guys understand this basic idea, you can basically solve almost any physiology question related to blood pressure. But let's try to build a little bit on it and like see how exactly it's going to change. Now, so if there's a problem in blood pressure, what's going to happen? It's going to be detected by the body, whether it's an increase or a decrease, and then the body will try to correct it. Let's take an example. First one is where there is an increase in the blood pressure. Now we said the equation says that the blood pressure is the cardiac output times the resistance. And since it's a multiplication, now this is not really related to the lecture, it's like the mathematics behind it. And since it's a multiplication, it's going to be directly proportional. So an increase in the pressure, or I mean an increase in the cardiac output or the resistance will lead to an increase in the pressure. However, if it was like a division, or if we say cardiac output over the resistance, then this will be inversely proportional. So in that case, an increase in cardiac output will increase that, but a decrease in the resistance will increase that. So like that's, anyways, we don't really care about that. So all this says is that if there is an increase in the cardiac output, there will be an increase in pressure. If there is an increase in the resistance, there will be an increase in pressure. Over here, I put for you guys some situations where there might be increase in the cardiac output or the resistance, but mainly I need you guys to take out hypervolemia, which is basically too much fluid, so that leads to higher stroke volume, or stress, which activates the sympathetic nervous system. And for the resistance, then you could basically think of the sympathetic nervous system, which is anything that causes too much constrictions, okay? So these are some factors that would lead to hypertension. Now, other stuff, like, of course, hypertension and these stuff aren't really like normal physiological. Sometimes they could be pathological situations, or sometimes they could be physiological. So we always need to look into that. But mainly keep this idea with you. Now, if we have this hypertension, whether it's an increase in cardiac output or a resistance that led to the mean arterial pressure, our correction should be lowering this blood pressure. So how will we do that? All right. So since we said that the patient has a high cardiac output or a high resistance, our correction will be by lowering these two factors, right? So now I'm sorry for this, it was visible, but now it makes sense. So our compensation will be, first thing we want to lower is going to be the cardiac output, right? And we said the cardiac output is going to be controlled by heart rate and stroke volume. The first thing we'll do is that we'll lower the cardiac output by lowering the stroke volume and the heart rate. And then what's the second thing that we should do? Lower the resistance. And this is done by vasodilation. And if you can look at the effects of vasodilation and decreasing stroke volume and decreasing heart rate, these three are going to be mediated by the sympathetic or the parasympathetic nervous system.
Parasympathetic?
Parasympathetic nervous system, exactly. So whenever there is an increase in the blood pressure, the system that is responsible for solving that problem is the parasympathetic nervous system. Because I want you guys to stop trying to understand it. Not that I want you to stop, I want you to stop memorizing it and just try to visualize it. If there's an increase in blood pressure, just visualize a vessel that is constricted and full of blood. And how will you solve it or solve that problem with this vessel? By opening it up and decreasing the amount of blood going through it. And this is going to be done by the parasympathetic nervous system. Is this clear?
I have one question.
Yes.
What exactly is achieved by the parasympathetic? The number two
Yes,
only?
no, both of them. The vasodilation and basically decreasing the resistance and the decrease in the cardiac output are achieved by parasympathetic. Yes.
What was the thing called hypervolemia? What does that mean?
Volume is basically volume or blood volume, and hyper is too much. So too much blood volume.
Oh, okay, thanks.
All right. No worries. Is this point clear for you guys all? Now let's go to the second part, which is the opposite effect. If there is hypotension or a decrease in the blood pressure, and again, I put for you guys some examples. Main takeaway here is the hypovolemia, which is the opposite of the hypervolemia, with a decreased blood amount, or autonomic dysfunction. Now, usually, autonomic dysfunction is due to sympathetic activity, but don't worry about it. Just focus on systemic vasodilation. Tamam? So vasodilations or hypovolemia are the main factors that will lead to hypertension. And again, similar to the hypertension, assuming we have a low blood pressure, then assuming we probably have either low cardiac output or a low resistance, or could be both. And so this is going to be detected by the body, and it will try to compensate, first of all, by increasing the cardiac output. This is done by increasing the contractility and the heart rate. And then it will increase the resistance by vasoconstricting it. And once both of these are increased, we're going to have a normal blood pressure. And is this going to be achieved by the sympathetic or the parasympathetic nervous system? By the sympathetic nervous system, exactly. So if you guys understood this concept, you are done with the hardest part of the lecture. You're done with 50% of the lecture. Is it clear? Do you guys have any questions regarding this? Okay. So here I put for you guys a small summary again of what exactly is what I said. So mean arterial pressure, you can have an increase in the blood pressure due to increase in cardiac output or resistance. Now atherosclerosis, I don't know if you guys took what that is, but atherosclerosis is basically when there is a plug that is blocking the vessel. Now, it's not really a cause of increased resistance, but I just put it as an example here because what happens is that it will close or make this vessel space smaller since it's blocking the vessel. Now, a decompensation would lead to decreasing the cardiac output and the resistance by the parasympathetic. On the opposite hand, if you have a low cardiac output, low resistance, means you have low blood pressure, the compensation will be increasing both of them using the sympathetic nervous system. All right. Now here's a checkpoint for you guys. I'll read the question and then I'll give you a second to solve it. Or I'll give you a minute to solve it, I mean. A 22-year-old man, or does any one of you want to read the question? Can I have one of you read the question instead? Okay, Omar, you can read the question and try to solve it.
22-year-old man enters the hospital emergency department after severing a major artery in a motorcycle accident. It is estimated that he has lost approximately 700 milliliters of blood. His blood pressure is 95 millimeter mercury. Which set of changes would be expected in response to hemorrhage in this man?
All right. So what do you guys think is the answer for this question? Okay, we got 3 answers. I'll give you guys a minute. All right, we got most of the answers. Now, mashallah, I see most of you guys got it right. So the correct answer here is A. Now, okay, I'll just explain it since most of you got it right so that we can keep going to the next part of the lecture. Now, basically, the main issue here with the patient is that he has a low blood pressure. Now, low blood pressure, we can assume he could either have a low cardiac output or low resistance. However, the scenario tells us that the patient has a low cardiac output. Now, correction of low blood pressure is by activating the sympathetic nervous system. So we're going to have an increased sympathetic activity. And the sympathetic nervous system, what it does is that it increases the heart rate and decreases the resistance by vasoconstriction, which can be seen right here. So the patient came with blood loss right here, and our correction was these 3. Okay. So mashallah, good job, you guys got the answer correctly. Now, the next thing we'll look into is the detectors. Okay, so yeah. Now, we said that the blood pressure changes are going to be detected, and then once we detect them, we do the changes. So we discussed the before, and we discussed how we reach the after, but we didn't talk about what exactly is going to detect this change. Now, this is the next part of the lecture. Now, what exactly are the structures detecting the changes in the blood pressure? Now, of course, since we're talking about blood pressure, we're most likely going to be talking about stuff or structures that are found around the vessels, because that's where the blood pressure is at, or where the blood pressure would be measured from. So, with that being said, our receptors for this changes in blood pressure are referred to as baroreceptors. What are baroreceptors? They are basically stretched receptors located around arteries. If you fill them up with blood, they're basically like, let me see if I got a picture. Okay, never. The picture is in the next slide. But it's basically, if this is a vessel, we can assume the baroreceptor is lying on top of it, okay? If you fill the vessel with too much blood, assuming, let's talk about hypertension due to increased blood flow, okay? If there's too much blood in the vessel, then the vessel is going to open up more and more and more. And as it stretches the vessel, as the vessel is stretching due to the blood flow, the receptors on top are stretching as well, okay? So when they are stretching, they will detect these changes. And if we're assuming it's a normal situation and the receptors are on top of it, and the vessel has a decreased blood flow this time, so it has a decreased blood flow, it will compensate by constricting, so it's getting smaller and smaller and smaller. The baroreceptors are not stretching as much. Now, how will this reflect on the activity of the baroreceptors? Okay, I got a question about, let me finish up this point and then I'll go to the previous question. 1 second. Okay, so we said that the baroreceptors have a normal firing rate, okay? So this is the blood pressure. At the normal blood pressure, they are firing at this level, all right? So this is seen as normal blood pressure. If there is more stretch in the vessel, there will be more firing, and it will look something like this. Now, where do you guys think this will be seen in? High blood pressure or low blood pressure? There's one low and one high blood pressure. Okay, so yeah, a bunch of high blood pressure, which is correct. If there is more firing, means the vessel is stretching more, and it will stretch more in response to increased blood flow and increased pressure inside of the vessel. So it will try to stretch to fill up or accumulate this pressure. And this will lead to increased firing, okay? And if there was decreased stretch or decreased firing, this will be seen in the opposite situation, which is a decreased blood pressure. At this point, clear. And I need you guys to take away the fact that baroreceptors will increase firing with increased stretch and decrease their firing with the decreased stretch, while in normal situations, they have a normal firing rhythm. All right? Is it clear? Okay, so I had a question about the previous slide. I'm gonna just go back to it. Sorry, guys. All right, so why is it not D? Now, what happens in D is that the sympathetic activity is correct, the heart rate is correct. However, sympathetic activity causes vasoconstriction, and with vasoconstriction, there is going to be increased resistance. And that's why it's not going to be choice D. And at the same time, like we're trying to correct the situation of low cardiac output by increasing the cardiac output by like increasing the heart rate and contractility, and by increasing the resistance through constricting. So that's why like it's not D. I hope that's clear. I hope that's clear. Okay. Now, so we said baroreceptors are going to be found around vessels. We have two types of baroreceptors. The main ones, like everything we discussed so far, is the high pressure baroreceptors, which since they're able to accumulate high pressures, they're going to be detecting pressure. And they're basically going to be responsible for all this vasoconstriction and vasodilation. Now, high pressure baroreceptors are found in three places, or three very important places. The first two are the carotid sinus and the aortic arch, which you can see right here. They're over the carotid sinus, and this is the aortic arch, the arch of the aorta. And now, most importantly, like most of the times I circled it here, the carotid sinus for you, because like most questions will be related to the carotid sinus. Now, the carotid sinus runs down the neck, and it should be over here. Around here, this is where your carotid sinus will be. And most of your questions will be talking about the carotid sinus. Very little of them will talk about the aortic arch. And now between the brackets, you can see I put the name of two nerves. Now these two nerves are the nerves that are going to be controlled by these baroreceptors. So if you activate your carotid sinus, you'll activate the glossopharyngeal nerve. Now the IX stands for cranial nerve number 9. So glossopharyngeal nerve has two names. It's either a glossopharyngeal nerve or a cranial nerve number 9. And the cranial nerve is just to differentiate between spinal nerves and cranial nerves. Cranial nerves are the ones for the head. So carotid sinus activates the glossopharyngeal nerve, and this is a really important point. Now the aortic arch, on the other hand, activates the vagus nerve, which is nerve 10. And this is also like another important point to differentiate between them. And the third baroreceptor is going to be one that is found in the kidney. And why I put it in a different section is that these two are going to be activating your sympathetic and the parasympathetic nervous system through your baroreceptors. However, the kidney receptors, or the kidney afferent arteriole baroreceptor, activates a different system that we will discuss in a second. Okay, but so this is just to tell you why I put them in a different situation. It's a system referred to as the RAAS system. All right, now let's worry about the first two right now, the carotid sinus and the aortic arch. Before we go into them and how exactly they're going to function, there's another set of receptors. Since we have the high pressure, we're also going to have our low pressure baroreceptors. Our low pressure baroreceptors are also called the cardiopulmonary baroreceptors, and their function, since they are only accommodating for low pressure, they can't really accommodate high pressure, they're only going to be used to detect volume. And where can we find them? We can find them in the right atria, in the vena cavas, and in the pulmonary arteries. Now, I looked through your slides. There wasn't really much mention about like what exactly is the importance of these low pressure. Now, I mean, they are responsible for detecting the volume, but in your slides, they didn't really discuss what exactly they do or how they control the volume. So I assume you don't really need to know about it. But only what they said in your slides was that they detect the volume and they regulate volume, and these are their locations. So I think that's all you should know about them. All right, now this is one other picture from your slide to show you another summary of what we said so far. But before we go into it, let's look into this part that I made for you guys. Okay, yes, Omar, you raised your hand.
Yes, carotid sinus. Sinus means a swelling.
Yes.
Okay, and
It's a
for
swelling of the carotid. Look right here, like it goes up there, and then it goes around there.
okay, nice. And for the cranial nerves mentioned, so for glossopharyngeal, it's related to the sympathetic, and the vagus is the parasympathetic, or
No, both of them are parasympathetic. It's just that when you stimulate the carotid sinus, the glossopharyngeal nerve is the one that takes the stimulus from the sinus to the brain. However, and like in the aortic arch, if the stimulation was done at the aortic arch, then it's the vagus nerve that takes it up.
Oh,
to
so
the
I
brain.
don't need to think about sympathetic, parasympathetic for this.
No. It's like parasympathetic for both. Yeah, but like what happens that once they reach the brain, both of them, the vagus and the glossopharyngeal, will act on one specific site. We'll discuss it in a second. So like mainly what you need to know about the vagus and the glossopharyngeal is that both of them are just taking it to the brain. And then of course, whenever the brain wants to activate the parasympathetic to the heart, like this is a question for you guys. What parasympathetic nerve controls the heart activity?
Vagus?
Yes, correct. So it's the vagus. So both the glossopharyngeal and the vagus nerve are just acting as conduits right here to take the signals to the brain. And then from the brain, the parasympathetic signal will be sent through the vagus to the heart.
Okay, thanks.
Okay? No worries. All right, let's go back into this slide. So we said this, and if we said or we took a situation where there was an increased firing of baroreceptors, and we said increased firing is an indicative of high blood pressure. Okay, allow me guys 1 last second. I'm sorry for going back, but I just want to show you this slide again, and I want it to be empty so that you guys can see like so the increase in stretch of so increased firing of baroreceptors means increased stretched means increased blood pressure. Okay, so like this is just to make it very simple for you guys. Whenever you read a question, don't think much about it. Increase in stretch, increase in firing, increase in blood pressure. Decrease in stretch, decrease in firing, decrease in blood pressure. So now if we go back here, if we said there is increase in firing, means there is an increase in stretch, means there is an increase in blood pressure. So our compensation will be to lower the blood pressure. Okay? So this is just like to help you guys whenever you see a question, so you can skip the trying to breaking down in your mind part and just go increase is increase, decrease is decrease. So signal is going to be sent to the brain. Now this is what we're going to discuss in this part. What exactly is going to happen in the brain and how exactly is your body going to try and compensate? Now we said, okay, this is a question. This first part is a question for you guys. If we said that the baroreceptors were firing so much, so increased firing, this is an indication of increased blood pressure. What is the compensation that we look for? What are the changes that we're trying to achieve? By decreasing the cardiac output and the resistance. Excellent, Sidra. These are the two things that we're trying to achieve. And the resistance is going to be done by dilation. Correct. Okay, so keep this in mind. Whenever the signal is going to be sent to the brain, we need to activate which system, the sympathetic or the parasympathetic, if it was too much firing and too much blood pressure?
Parasympathetic.
Exactly. So we're trying to achieve the parasympathetic nervous system. Now, this slide from your lectures is a little bit confusing. I don't understand that, but inshallah, we'll try to break it down. Now, if you don't understand it from the first time, it's totally okay. It's a little bit advanced slide, but I'll try to break it down. If you have any questions, please let me know and I'll repeat it again. Before we go into it, we said that let's take our position from this place, the carotid sinus. There's too much firing, there's too much blood pressure. The carotid sinus, which is the conduit for it? It's cranial nerve number 9, which is the glossopharyngeal. Or the vagus nerve, if it was for the aortic arch. Both of these nerves, as you can see, they will act on this green area, or this blue region in the green box. Now, what do we call this place? This is our most important control center for the baroreceptors. This is referred to as the nucleus tractus solitarius, right? What is it called? The nucleus tractus solitarius. This is our main regulator and controls everything, and it understands the signal of the baroreceptors so that we can activate the parasympathetic. Now, what does the nucleus tractus solitarius do? First thing it does is that it wants to activate the parasympathetic nervous system. And this can be seen right here. The parasympathetic nervous system is controlled in this area known as the cardio-inhibitory center. And it does make sense because what does the parasympathetic do? Parasympathetic inhibits the heart contractility, it inhibits the heart rate, it basically causes vasodilation. So like it does make sense if we're calling it the cardio-inhibitory center. So the cardio-inhibitory center is going to be the parasympathetic. Okay, wait, it's not sympathetic, I'm sorry. It's just the parasympathetic nervous system. Yes, so the cardio-inhibitory center is the parasympathetic nervous center. Okay, so now this cardio-inhibitory center is made of two parts, the nucleus ambiguous and the nucleus of the vagus. And again, it also does make sense because you guys just told me a few minutes ago that the vagus nerve is the one that is going to be sent out in order to inhibit the heart activity, right? So it does make sense to have the vagus with the parasympathetic area. So is the first part clear? Nucleus tractus solitarius activates the parasympathetic, and we achieved the first thing that we want to do, activating the parasympathetic. And it's done by the nucleus ambiguous and the nucleus of the vagus through the cardioinhibitory center. Now, we also got this other part. What does this part, what exactly is the reason for this part? We're basically not only trying to activate the parasympathetic, at the same time, we want to inhibit the sympathetic, because the sympathetic, what it does is all it will do, it will make the blood pressure even higher by increasing the cardiac output and the heart rate and the resistance. So if we inhibit the sympathetic and activate the parasympathetic, that will help us reach a normal blood pressure faster, okay? Now, it's a little confusing here why there is a plus and a minus. Now, the main reason for the plus and the minus is that the nucleus tractus solitarius, first of all, sends this neuron to an interneuron, which is basically like a neuron between both centers. It activates this interneuron, and then the interneuron is going to achieve the inhibition of this region here, which was referred to as the vasomotor center. Now, this sympathetic right here, it should have been right here, and the parasympathetic should be up here. Now, I'm sorry, I don't know. I don't know why it was there, so I apologize for that. But basically, the vasomotor center is the sympathetic, and it also does make sense to be called that because whenever we talk about motor, we're talking about movement and activity. And what the sympathetic does is that it increases the heart activity. So if we have a vasomotor center, then we're talking about a center for increasing the activity. So which is most likely the sympathetic, right? And that's why if you look at the final effect on the vasomotor center, it is going to be this minus or the inhibition. So in other terms, you can cross out this entire interneuron connection and take out what the nucleus tractus solitarius does. It activates the parasympathetic cardioinhibitory center through this plus, and it inhibits the sympathetic through the vasomotor center. And then the signals will be sent down through your spinal cord and then go out to your adrenal medulla and the heart and the blood vessels. Is this clear, guys? Do you guys get the effects of the nucleus tractus solitarius? Okay. All right. I'll explain it again. Okay, I'll go over it again for you guys. Sorry about that. Okay, so we said that the first, okay, let me just erase up the inking that I made. Okay, yes. Now we said that, wait. My bad. Again, apologies about that. Okay, so we said we have two receptors for the baroreceptors that we're going to discuss for now. The aortic arch and the carotid sinus. Both these guys will send through the vagus and the glossopharyngeal to this main guy, the nucleus tractus solitarius. Now, we said that the increased firing is an indication of a high blood pressure, and we try to solve it by lowering the blood pressure through lowering the cardiac output and the resistance, mainly by activating the parasympathetic. And in order to achieve a low blood pressure faster, not only do we activate the parasympathetic, we also inhibit the sympathetic. So the function of our nucleus tractus solitarius is basically telling the brain that we have high blood pressure, so we need to lower it by activating the parasympathetic and inhibiting the sympathetic. And since it understood that, then the nucleus tractus solitarius will work on what it understood, so it will do that. So the first thing it does is that it will plus or activate the cardioinhibitory center, which is the parasympathetic nervous system. What sympathetic, in order not to just memorize it and to understand it, so it's inhibiting, and the parasympathetic inhibits the heart rate and the contractility, so it does make sense to be called the cardioinhibitory center. And the cardioinhibitory center is made of two nuclei, as you can see, one for the vagus and one known as nucleus ambiguous. Okay, and again, we said that it does make sense. Why is it called the vagus? Because the vagus is for decreasing the activity of the heart. So this is on one end. We activated the parasympathetic right now. The next thing we need to do is, so we send an inhibitory signal towards this nucleus or this area known as the vasomotor center. This area is for the sympathetic nervous system. Okay, so this area is for the sympathetic, and it does make sense to be called the vasomotor center, to be for the sympathetic, because we know sympathetic is increased activity, and so vasomotor, motor is like usually you'd associate motor with activity or moving, so it does make sense to be called that, and that's why we're going to inhibit it. And then once we inhibited the sympathetic and activated the parasympathetic, we send our signals down the spinal cord and we activate the heart. We act on the heart and the vessels accordingly. Is it clear now?
I have a question.
Yes.
What is the thoracic cord? Sorry.
What is it?
Thoracic cord.
Where's the thoracic cord?
On the right.
Oh, this one here? It does just mean that it's the thoracic section of the spinal cord. You don't have to worry about it.
Okay.
Yeah, you don't have to worry about it. Like, if you understood what I explained to you, that's like almost, that's more than enough. There's just one other point that I need to explain to you guys, since it's mentioned in one of his slides. It's that the bulbospinal pathway. Now, what I want to mention is that the bulbospinal pathway is the pathway that is taking from the sympathetic nervous system down the spinal cord to activate, okay? And since we inhibited the sympathetic, we also inhibited the bulbospinal pathway. So this is my only other point that I wanted to add it to what I explained previously. Now, is it clear? Do you guys have any questions?
So the left-hand side is just the same plus then minus نفس الفكرة.
Okay, so the spinal cord is like two sections, one on the right, one on the left. Even for the brain, it's always like two sections, one on the right, one on the left. And then every section controls a part of the body. So like the right part, let's just say that the right part controls the right part of the body, and then the left part controls the left part of the body. So that's why like we have two parts which are identical. So if we draw a midline right here, this part is the same as this part. And one other point I want to add is that you guys here can see GLU and GABA. These are neurotransmitters. So neurotransmitters, if you remember, like in foundation, we discussed neurocrine signaling, and this is done by neurotransmitters. The neurotransmitters of the brain and the nervous system are GABA and glutamate. GABA is inhibitory, glutamate is excitatory or activates. So here you can see a GLU at first because we activate this interneuron, and then there is GABA to inhibit the final pathway. So like finally we're just inhibiting it by GABA. I just didn't want to explain it at first so that it's like extra details and you're most likely not going to get asked about it, but just in case you see it in the slides and you get confused about it. Okay. Now
So
there's
can
a
I
question.
say that?
Yes.
So
What is it?
can I say that that GLU equal to caudal ventrolateral medulla?
No. Wait, let me type it. Hold up. I might end up screen share. Okay. Yes. Wait, I'm gonna start a screen share again. Okay. So GLU equals glutamate, and GABA is GABA. GABA is inhibitory neurotransmitter, and glutamate is excitatory neurotransmitter. It's just a neurotransmitter. It's similar to adrenaline. It's similar to norepinephrine. It's similar to dopamine. Like it's just a neurotransmitter.
Yes. I mean, does it do the same function of caudal ventrolateral medulla? Because
I'm not sure. Like it's glutamate is basically gonna Nucleus tractus solitarius activates the caudal ventral medulla through glutamate. And then the caudal ventral medulla is the interneuron that we discussed that is going to inhibit the vasomotor center. Is that answering you,
Okay.
or did I get it wrong?
I mean, does like GLU make the same function of caudal ventrolateral medulla? And because we said both like excites the inhibition of either GABA or vasomotor center.
Technically, yes, but like wait, let me just break it down because like they're two different things. The nucleus tractus solitarius sends a neuron. This neuron speaks to the caudal ventral medulla. So like we have a nucleus tractus solitarius, we have a caudal ventral medulla. They speak to each other through glutamate. Okay. So if the nucleus tractus solitarius wants to activate the caudal ventral medulla, it activates it through glutamate. Now we have the caudal ventral medulla, it's active. So this is the control ventral medulla, it's active. It wants to talk to the vasomotor center and it wants to deactivate it, then it sends a GABA. Okay, so we got three guys. There's one, there's two, and then there's three. Did that make it clear to you?
Yes. Okay, thank you.
If you don't understand it, like I can explain it again, but yeah, you can send me a text and I'll explain it to you again, just so that we don't take much time on it. All right, let me just see the chat because some of you guys have questions. Bulbospinal is a paravertebral ganglia. No, so the bulbospinal is just a pathway. What does it stand for? So you guys can break it down. Spinal is for the spinal cord, so it means it passes through the spinal cord. And bulbo is just referring to the fact that it comes from the brain. So bulbospinal pathway is the pathway taking it from the brain through the spinal cord to reach its way. And the bulbospinal pathway is holding this is the only thing that I said about the bulbospinal pathway, is that it's holding the sympathetic activity. Okay? So if we inhibited the vasomotor center, we inhibited the bulbospinal pathway. Okay. And there was another question, do we need to know the caudal ventral medulla? I don't think you guys need to know the details of this picture. None of the details, I don't think you guys need to know them. However, do make sure of the previous batch before you, the 15th batch, and your doctor. But if I'm not mistaken, I'm pretty sure like nothing from this like graph that you guys need to know. I just wanted to explain it in case you guys were going over it. And there was another question. Cardioinhibitory center is for the parasympathetic and vasomotor is for the sympathetic. Yes, correct. So the sympathetic should have been here. Is it clear? Is this part clear? Right. Yes. Okay. Inshallah, it's clear. Now, I put, wait 1 second. Let me just take back my pen. Okay. So in the next slide, I did put like some breakdown of what we said in text. So I said that glutamate is just a neurotransmitter that's going to be for exciting, and GABA is going to be for inhibiting. And then vasomotor center, which was sympathetic, is through the bulbospinal pathway. And cardioinhibitory center is parasympathetic, which has these two nuclei, vagus and the nucleus ambiguous. If we have too much blood pressure, we're going to activate the nucleus tractus solitarius. If there's too much blood pressure, activate the nucleus tractus solitarius in order to inhibit the sympathetic and to activate the caudal ventral lateral nucleus in order to inhibit the vasomotor. So we inhibit the sympathetic and we activate the parasympathetic through the cardioinhibitory center. Is it clear? Another summary of the previous slide. So we said if there is an increase in cardiac output, there's increase in blood pressure. So the goal will be decreasing the resistance and decreasing the cardiac. It's basically just the same thing. Now let's look into the slide. This was a big slide in your lectures, but also it's like all about that one graph. Let's go through it together. I need you guys to answer with me if it's going to increase or decrease. The first one, the efferent activity in the bulbospinal pathway. If we have an increase in blood pressure. Okay, I have a question before we go into that. If we have an increase in the mean arterial blood pressure, are the baroreceptors going to fire more or less?
More.
Baroreceptors are going to fire more, correct. So I'm glad you guys all understood that part. Okay, let's go through the questions here. So the efferent activity in the bulbospinal pathway, increased or decreased? Decrease, decrease, decrease. All right, correct. You guys are correct. It will decrease because we said bulbospinal pathway is sympathetic. So we want to lower the sympathetic. Next one is nucleus ambiguous. Increase or decrease?
Increase.
Decrease, correct. Of course, this is the parasympathetic. The next one is the vagus.
I think it increases.
Increase. Yes, correct. Sympathetic neurons. Decrease.
Decrease.
Resistance.
Decrease.
Decrease. The carotid sinus afferent.
I think increase.
Yes, you guys just answered it. It's basically like increased firing of the baroreceptors. So it's like the question I asked you guys at the start. Okay, so the output from the vasomotor center,
Decrease.
correct? Oops. Nucleus ambiguous,
Increase.
correct? Ninth and 10th cranial nerves,
Increase.
correct? Glossopharyngeal, similar to the 10th.
Increase.
Vagal innervation, increase. The slope of phase 4 of the action, decrease. Because if a decreased slope means that it will take longer. If it's an increased slope, then it's more steeper. So like we decrease the slope. You get it, right? You get why?
Yeah.
Okay. Because I got confused with it at the beginning. I forgot math. Anyways, so cyclic AMP concentration
Decreases.
decreases, correct? Because mainly cyclic AMP is associated with contraction. Epinephrine,
Decreases. I think all of them decrease.
yes, correct. Calcium is also concentration.
I have a question.
Yes.
Why
Regarding the
does
slope, I'll
the
explain it in a second.
activity of 9 and
Oh.
10 cranial nerves increase?
Because 9 and 10 are the baroreceptors. Since the baroreceptor is firing more, so they're sending it through cranial nerve 9 and 10. Remember in the... Wait, I'm not going to go through that. 1 second.
So they will continue firing until the
Right
BP
here.
is down, right?
Until we lower the blood pressure, yes, correct. Until we correct it, they're going to be increased firing.
Thank you.
No problems. All right, and for the slope, since YTPR decrease, the resistance is decreasing since we activated the parasympathetic and we inhibited the sympathetic. And we do want to achieve that because we have a high blood pressure already, so we're trying to lower the blood pressure. So we reached our goal by doing that. So that's why we decreased the resistance. Now, regarding the slope, so the slope of phase 4 of SA nodes, if you guys remember the action, wait, let me get the pen. So yeah. I'm sorry, I'm gonna draw it on my touchpad. So if it looks bad, it's because I'm on the touchpad. Now, SA node cells, their action potential was something like this, if you guys remember. So yeah, so the phase 4 is right over here. If we have an increased slope of phase 4, so it will look something like this, which is the higher slope of phase 4. I mean, a lower slope of phase 4. It will look something like this. This is a decrease in the slope. And as you can see, like it takes way longer compared to this. So basically what this means is that there's a lower heart rate. So by decreasing the slope, we decrease the heart rate. And decreasing heart rate is done by the parasympathetic. And increase the slope, this is an increased slope, this is a decreased slope. So yeah, it's just that the math confuses us. All right. All clear, guys? Here's the checkpoint for the baroreceptors part.
Can you go back 1 second?
Yes. If you have a question, I'll tell you the slides after. Just let me go through the question. If you have a question, let me know. Okay. So who would like to read the question and try to answer it? Does anyone like to try to read the question?
A
May I?
20-year-old college student was brought to an urgent care clinic with severe headache. Her friends reported that she drank several liters of water in the previous hour as part of a game to see who could drink the most water, most without urinating. The physician suspected overhydration, also called water intoxication. As part of the body's compensatory reflex against elevated blood pressure from the overhydration, the activity of which component of the baroreceptor reflex is most likely to be decreased in this patient?
Okay, so the patient has high blood pressure. Now, with high blood pressure, is there going to be more or less firing of the baroreceptors? All right, never mind. I'm gonna give you guys a chance to answer it, and then wait. Did I show the answer? Oh, oops. Okay. So I'm gonna give you guys a chance to answer, and then we'll try to break it down together. All right, most of you have said E, which is the correct answer. So I'm glad you guys understood. Okay, wait. It's okay. So how E? Okay, so let me explain to you. Now, we said that the patient has high blood pressure, okay? So you guys tell me, with high blood pressure, is there going to be more or less firing of the baroreceptors? More firing. So more blood pressure, more firing. If there is more firing of the baroreceptor, it will go to the nucleus tractus solitarius. So if it's going to the nucleus tractus solitarius, are we activating it or are we deactivating it? If we're sending it signals and we're speaking to it, the nucleus tractus solitarius will be active or deactivated? Activated. So we cross it out. Now, what the nucleus tractus solitarius will do is that it activates the parasympathetic. We also activated the baroreceptor, so we cross that out. Now, parasympathetic is activated through the vasomotor or the cardioinhibitory center. Cardioinhibitory center, and since we're activating it, it's not going to be the answer. And parasympathetic is also not the answer because we're activating parasympathetic activity, and which leaves us with E. And it does make sense because we inhibit the sympathetic. So if you just cross throughout all that process and go to what's inhibited, we inhibit the sympathetic, which is the vasomotor center, and this is why the answer is E. Now there was a question for the previous slide. Vagal innervation of the SA node would decrease. We want to decrease the heart rate. Why would it increase? Which part is it? Vagal innervation of the SA node. Oh yes, because we're increasing the vagal activity. We want to decrease the heart rate. Yeah, so since we want to decrease the heart rate, we want to inhibit the SA node more. And the vagal innervation is inhibiting the SA node. That's why it's increased. So basically, when we're saying increased vagal innervation, we're basically saying increased inhibition of the SA node. Does that answer your question? Okay, no problem. Here's another checkpoint for you guys. While participating in a cardiovascular physiology lab, a medical student isolates an animal's carotid artery. Sorry for reading it. Does anyone want to read it?
Can I read it again?
May I?
Yeah, sure.
While participating in the cardiovascular physiology laboratory, a medical student isolates an animal carotid artery proximal to the carotid bifurcation and partially constricted the artery with a tie around the vessel. Which set of changes would you expect to occur in response to the constriction of the carotid artery?
All right. Now, this is a little bit of a different question, but it's the same concept. If you understood the concept of it, it's going to be the same way to solve them all. But I'm going to give you guys a chance to try and understand what's happening. Okay, so far the answers are split between either complete sympathetic activity or complete parasympathetic activity. And now there is a B, which is an in between. All right, would anyone like to answer it, or should I break it down with you guys?
May I try?
Okay, sure. It's just one part that you need to break down. What exactly happens here?
Of the artery,
Hmm? Like,
which
if you
means
understood
that we
this,
increase the resistance.
wait, can you repeat that?
Okay. Constriction of the artery means we will have a higher resistance because there is something narrowing the blood vessel or the artery, and by doing this we will increase also the pressure, which will increase the heart rate.
Okay, so let me explain exactly what's happening here to you. Now, this patient here, his carotid artery was blocked. It wasn't blocked because of some high blood pressure or some resistance from the actual person. What happened here is that there was a tie around the neck, and we said around the carotid, so ignore the neck. So around the carotid, okay? If we have blocked the carotid proximal to the bifurcation, what does this mean? So if So if we said that the carotid comes out of the heart, proximal means that it's closer to the center of the body. Distal means it's farther away from the center of the body. So if it's proximal, means it's closer to the center. And we said that the baroreceptors are more distal, right? So if we closed it with a tie, more proximal, or like towards the center, okay? We close this area around here. Do you think blood can pass through this constriction and continue its way up to the baroreceptors? If it's blocked here, can it reach this area? If we block it here, can it reach this area? Correct. It can't reach this area. And we said the only way the body understands when we have low blood pressure or high blood pressure is through the baroreceptors. So it doesn't really understand that underneath here we have a lot of blood that's piling up because of this constriction. All it understands is that this baroreceptor, does it see blood or does it not see blood? You guys answer me. Does this baroreceptor here see blood or not? It doesn't see blood. So what does it do? Does it increase its firing or decrease its firing? It decreases its firing. Wait, so there was an increase. It actually decreases its firing because there is less blood pressure. So there is low blood pressure. With low pressure, there is low firing, there is low stretch, there is low activity. So we have low activity of the baroreceptors. And since there is low activity of the baroreceptors, there is going to be more sympathetic and less parasympathetic. It's going to be the opposite of everything. It's going to have more sympathetic this time and less parasympathetic. So with more sympathetic, we're going to have more heart rate and more resistance, leaving the answer to be A. Did you guys get it? Yes, Omar?
Can you explain it again, please? Sorry.
Okay. So we tied the vessel around here, and the baroreceptor is around here. Okay? So we said, since it's tied around here, the blood can't pass through, and the baroreceptor doesn't see blood. So the body doesn't really understand if we have too much blood pressure or too little unless the baroreceptor speaks to it. So what does the baroreceptor see? It sees that we have a low arterial pressure because everything is pulling down. It sees that we have a low arterial pressure. So with low pressure, what happens to the activity of the baroreceptors? Will it increase or decrease?
Decrease.
It decreases the activity of the baroreceptors. And if there is a decreased activity of the baroreceptors, will this lead to more parasympathetic or more sympathetic?
Sympathetic.
No, it's the opposite, more sympathetic, because we switched it. If there is increased baroreceptor, there is increased sympathetic. If there is decreased baroreceptor, there is decreased parasympathetic. So like kind of associate. So let's remember how we said high mean arterial pressure means high baroreceptor firing. Let's add to it this time means higher parasympathetic activity, okay? So high arterial pressure, high baroreceptors, high parasympathetic. So this way we have like 3 increases, and that makes it easier for you guys to catch on to it, okay? So again, high blood pressure, high baroreceptor firing, high parasympathetic, which is similar to everything that we explained so far, okay? And now low baroreceptors, low blood pressure, low baroreceptors, low parasympathetic, more sympathetic. Okay. Now there was a question.
But
yes.
The problem is that I didn't get the distal and the location part, and
okay.
Why it's less firing.
Okay, because we said that the baroreceptors are not found everywhere, right? We said at the start that high pressure baroreceptors found in the carotid sinus, over the carotid sinus, over the aortic arch, okay? And so let me open up this so that I can draw for you guys. Okay. Now, since we have them over here, and this is the center of the body, proximal means closer to the center. So maybe it's something around here. And again, in the question, it said before the bifurcation. Oh, this is the bifurcation. So if it's proximal and before the bifurcation, it's compressed around here. So we have a lot of blood over down here and very little blood up here. So the baroreceptors aren't receiving as much. Now, I do understand that there are some as well baroreceptors here, but it's like the main concept of it, or the main point of it, is that at the carotid sinus, because we're compressing it or we're constricting before the carotid sinus, there is no blood going up. So there is low blood pressure pursued by the body.
Okay, so the bifurcation, where was it again?
Here's the bifurcation of the carotid, right here.
Oh, okay. Oh, okay. Okay,
And
fine.
then at the carotid sinus is where you can find the baroreceptors. So we're constricting it over here. There is too much blood down here, but too little. If it was going to be here, there's going to be more firing. But since the baroreceptors are here, there's less firing. Clear?
Okay, thanks.
No problems. All right. We went through this, right? Oh, wait, no. Yes, because we care about the carotid and the aortic arch. All right. Now, here is just one last part. Remember how we set the signals to the brain? Now we understood the signal to the brain, what happens, and this is the compensation. So in other words, more firing, more blood pressure, more firing, more parasympathetic. Just takeaway. Okay, this is your final takeaway. More blood pressure, more firing, more parasympathetic. Less firing, less blood pressure, less sympathetic. Okay, so more baroreceptor, more parasympathetic. Less firing. Oh, oops, this should have been decreased. 1 second. My bad. All right. So less baroreceptor, less parasympathetic. All clear, you guys? Okay. One last point regarding the baroreceptors. Just give me a second. Let me check. Is it clear with you guys? Does anyone have any questions? If you understood this part, خلاص, you understood like 90% of the lecture, you can solve almost any physiology question you get in the midterm, inshallah. Just keep whatever we said in mind, and any physiology question, any pathology question, any heart problems you get, just keep this in mind. Break it down this way, and inshallah you'll get it right. Okay, I'm glad you guys understood it. And my number is in that first slide if you wanted to message me anytime. Okay, now so the carotid massage, one last thing is that sometimes old people, what happens is that, you know, they try to help them by massaging their carotid sinus. And if they massage the carotid sinus, can you guys tell me what system is going to be activated, the parasympathetic or the sympathetic, if you're massaging the carotid sinus?
Parasympathetic.
Correct, parasympathetic. Because basically, if you're massaging it, then this is going to be more firing, and more firing is going to be more parasympathetic. If you guys get this, inshallah, and everything else should be easy for you. And now, rest is just going to be like some small slides. In chronic hypertension means someone that has hypertension for a very long time. Like if you're someone who's sick and you have hypertension like as a chronic disease for years of your life, what happens is that your baroreceptors, instead of firing at, for example, 120 and 80, they start firing at 130 and 90. So this is all what this picture says, is that the baroreceptor firing rate is pushed a little to the right for higher blood pressure. Now, this is the last part, which is the special baroreceptors, the renal arterioles. I do need one of you guys to tell me if Dr. Simon explained it, because I remember last year he didn't. However, this is still in your slide, so I want to know if he explained that part, the renal angiotensin and aldosterone. He did?
He said
to know that
leave this for renal.
He said leave it for renal?
Yeah, I think
Yes,
so.
he said we're going to take it in the renal block. He just went over it like slightly, briefly.
All right. Then I'll do the same in that case. So the baroreceptor, the last one, why did I put it as special? Is that so it functions in the same way. If there is more blood pressure, more firing, less blood pressure, less firing. The only difference is that if there is more firing, or no, the only difference is that the change is not going to be controlled by sympathetic and parasympathetic. The change is going to be done through the RAAS system, or the renin angiotensin aldosterone system. Okay, and if you understand the function of the renin angiotensin aldosterone system, which I wrote it down here, then what it does is that it will constrict your vessels and increase your blood volume. You guys should be able to tell me when we will have a release of renin angiotensin aldosterone system. Okay, so if we said that the renin angiotensin aldosterone system, or the RAAS system, constricts the vessel and increases the blood volume, is it going to be released when we have low blood pressure or when we have high blood pressure? When we have low blood pressure. Exactly, because the compensation is increasing the blood pressure. So the stimulus must be a low blood pressure, okay? And if we have a low blood pressure, then do you have more or less firing? I don't think you really need to know about the firing of this guy. Just know if there is a decrease in blood pressure or blood flow through the afferent arteriole, there's going to be compensation by vasoconstriction and decreasing blood flow through the RAAS, okay? So one last time, I'm going to say it. If there is a decrease in flow through the afferent arteriole, which is an indicator of low blood pressure, the compensation is going to be by constricting and increasing the blood volume through the RAAS system, right? Now, I do, guys, want to mention something. I know, like, I don't want to take much of your time, but it came to our exam. However, our doctor was different, but I'm just going to mention it just in case it does come to your exam as well. Now, in the RAAS, like similar to the carotid question that we had earlier that I put for you guys, where there was some type of occlusion, you might get a question with a patient that has some occlusion of the renal artery, okay? If I told you a patient has an occlusion of his renal artery, will there be an increase in RAAS or a decrease in the RAAS system?
Increase.
There will be an increase in the RAAS system, correct? Because if there is occlusion of the renal artery, then the afferent arteriole, so we have an occlusion over here, okay? All the blood is back there. There is no blood here. So this is a low blood pressure, which is our stimulus for these two. خلاص, inshallah. If you guys get this part, and if you see any questions of the renal arteries, you guys should be good, inshallah. All right. I just put for you the slide if you want to go through them, and then this again. And this is for the clinical significance. Okay. Now we're done with 90% of the lecture and like the major part you need to know. The rest is going to be like a few points that once I mention them, inshallah, they'll stick in your head, and I don't have to mention. You don't have to even revise them. Like once I mention them, inshallah, you'll be good with them for the rest of the block. Okay, so the next thing we're talking about is flow. So we discussed pressure, we're done with pressure. Now we're going to be talking about the blood flow, okay? So we have two things in order to control the blood flow. We have the metabolic theory, which is the first one, and then the other one is going to be the myogenic theory or the muscle theory. Now the metabolic theory is the first one. Metabolism, okay? So the first thing that comes to your mind whenever you hear the word metabolic is metabolism. And can you guys tell me what metabolism is?
Breaking down of food.
Exactly. Metabolism, you're breaking down stuff, you're trying to release energy. So you're using, in other words, you're using some oxygen and some sugar in order to release carbon dioxide and energy. I'm gonna write E for energy, okay? So basically like chemical reactions in our body. Exactly. So this is what metabolism is. Now, my takeaway from this entire thing is that if a tissue is undergoing too much metabolism or excessive metabolism, it is going to use up all its oxygen and glucose, and there will be a buildup of carbon dioxide. Ignore the energy, there will be a buildup of carbon dioxide, right? So if there's too much metabolism, there's going to be a buildup of carbon dioxide and a decrease in oxygen and glucose, right? So this is our basis of understanding. Next thing we need to know is that, our body, our tissues, we need oxygen to function, right? So we need oxygen. So does our body or do our cells like this state? Now we're talking, okay, so I do have to clear this point up, that we're talking at a cellular level and not a whole body level, okay? So assuming you're exercising, only your skeletal muscles or your muscles in your legs or your arm, whatever muscle you're exercising, are the ones that are undergoing excessive metabolism, okay? Not your entire body, tamam? So with that being said, let's go back to our example. Let's say you're exercising, you have too much use of oxygen and glucose in your muscle, too high carbon dioxide, too low oxygen and glucose. This is actually a very nice way our body tries to compensate. When it sees that we don't have our oxygen and glucose, it opens up the vessel and it vasodilates the vessel. Why exactly does it vasodilate? Because there's a major point you need to understand, and you guys probably could get it with common sense. Do you think blood flows more in a constricted or a dilated vessel? Do you think blood flows more in a constricted or a dilated vessel? In a dilated vessel, exactly. So this is why we dilate the vessel. We open up the vessel wall to take away the waste products and remove them through our blood, whether it's through the urination or through the respiratory. So we just take them away and we dilate them to allow more oxygen and nutrient-enriched blood to come in. Is it clear? This is basically all you need to know. metabolism, we open up the vessel so that we can keep the metabolism going on. We remove the waste and we get the oxygen. Next. So there's other metabolites that can be released other than carbon dioxide and oxygen. You can have adenosine. So adenosine is the byproduct of ATP. You know, when you're using your ATP and energy, you end up with adenosine. You can have lactate, which is you're going to take it later in mol 1. But basically, lactate is also going to be released when you're using up your energy and you're breaking down glucose. And then you got some ions. You don't really need to worry about them. Just mainly understand any waste product is going to cause vasodilation. Any decrease in oxygen will cause vasodilation because we need to get these stuff going. And also there's a bunch of paracrine agents. I did write their functions here, but basically just that they act. Angiotensin 2 is from the RAAS system. You guys can read them on your own. I really doubt they might ask you about these. So if you understand that metabolism causes dilation, this should be enough. Now, the other one is the myogenic theory. Now, myogenic theory is not the same as the metabolic theory. There's two myogenic theories that I'm going to explain to you. The first one is like a little bit, the first one is going to be associated with the muscles, and then the other one is going to be nitric oxide. I'm going to go with the nitric oxide one first because it's easier. All I need you guys to know, whenever you hear the word nitric oxide, it's vasodilation. Is it clear? Nitric oxide is vasodilation. Okay? خلاص. This is like from now for future blocks, for future years, for whatever you see. Nitric oxide, vasodilation. And it acts through cyclic GMP. And nitric oxide, it's going to be released from the endothelium. And if you remember from your histology, endothelium is like the innermost layer of this base of this of the vessel. So the inner layers of the vessels are the nitric oxide, are the endothelium. Whenever there is shear stress or too much blood flow going through, you know, you get this nitric oxide causing vasodilation. It causes vasodilation. All you need to know about nitric oxide is that it causes vasodilation through cyclic GMP. Now, for the first one that we didn't discuss, myogenic reflex. So we said we got the endothelium layer. Underneath the endothelium layer, we got the muscles layer. Okay. Now, what you need to understand about the myogenic reflex is that whenever there's like too much stretch on the vessel wall, like if there's the vessel wall was, you know, you're just sitting normally, and then suddenly you got this insane like or huge gush of blood flow flowing through the vessel. So what happens is that the muscles are going to be stretched, and since they're being stretched, you have an opening of the voltage-gated calcium channels, and this will cause reflex constriction. Okay, so the myogenic reflex, all it says is that the muscles, when they're stretched due to a large, like a sudden large blood flow through the vessel, the muscles will have a reflex constriction. Okay, clear? And it's present in not all the organs, only in the brain, the renal, and then some splanchnic organs. So splanchnic is just like organs of your GIT, for example, organs like in their internal organs, basically. Are these two clear?
Can you repeat number 1?
Myogenic reflex?
Yeah, please.
Okay. So if you have a lot of blood flowing through the vessel, we said the first thing that happens, you know, is that there's too much blood flowing through. The muscles are going to be stretching, you know, because blood flow is pushing them apart. So they have a reflex constriction. And then they're going to start to adapt and then to develop and maybe activate baroreceptors and whatever. So just immediately myogenic reflex is a reflex vasoconstriction.
Okay.
And nitric oxide is vasodilation. Now, last part of the lecture, it's going to be a very quick part. Autoregulation, active hyperemias, and reactive hyperemias. The first one is autoregulation. Autoregulation is a mixture of both the myogenic and the metabolic. What does it say? It's basically saying that there are certain organs in our body that I have mentioned. Yes, so there are certain organs in our body, such as the brain, the heart, and the kidney. These organs, they want to have a normal blood flowing through them, right? They want to have the entire time a normal amount of blood flowing through them. We said that when there is constriction, there's going to be less blood flowing through, and when there is dilation, there's going to be more blood going through. But these organs, they don't want that. They just want their normal amount of blood going through them, okay? They don't want to be affected by these changes. So they have an autoregulation mechanism in order to do that. And basically, so in other words, all autoregulation says is that at a certain blood pressure ranges, these organs maintain a normal blood flow due to the myogenic and the metabolic theories. Clear? That's all. That's about it. Normal blood flow due to with whatever changes in pressure in this specific range. Okay, if it goes out this range, then there's going to be changes due to these two theories. Use both. Use the myogenic and the metabolic theory. Yes, they use both of them in order to regulate it. Now, the other one is hyperemias. We got two hyperemia, active and reactive hyperemia. The first thing, just before we get into it, I'm going to just tell you guys what hyperemia means. Hyper, you guys should be very familiar with it right now. It means too many or too much. And emia means like blood flow. So hyperemia means increased blood flow. Okay? Now, when we say active hyperemia, then assume we're talking about active muscles. Okay? So active hyperemia is that this muscle is active, so we need to give it more blood flow. As a result, there's going to be increased blood flow in this muscle because of its activity, okay? Hypervolemia is too much blood or too much blood volume. For example, in your normal blood, there's about, I'm not sure about the numbers, let's say you got 2 liters of blood in your body. If we have hypervolemia, then maybe you have about 3 liters of blood. And hyperemia is that there's too much blood coming through, increase of blood flow, and not blood volume. So just an increase in the blood flow. Okay. And I do want to point out here that hyperemia, whether it's active or reactive, it's only metabolic theory. Okay. Remember the autoregulation, we said it was done by both metabolic and myogenic. However, this one is only metabolic theory. So just from its name, active hyperemia, the muscle is active, there's metabolism, there's increased blood flow. Muscle is here, we start our exercise, we increase the blood flow. The other one is reactive hyperemia. It's basically reacting. So what is it reacting to?
Can you repeat active
hyperemia?
Hyperemia, please.
Okay, so from its name, active, we're assuming activity, okay? So if there is increased activity, our body is nice. If you're working, they're gonna give you more stuff. So if a muscle is working, we're gonna supply it with more blood flow. That's about it, okay? So active, since the muscle is active, we're giving it more blood flow. So if we see right here, it wasn't active at the start, so there was no reason to give it more blood flow. It started exercising around here, we gave it more blood flow. It was done exercising, we took away the extra blood flow.
So in active hyperemia, basically we're gonna have hypoglycemia and low oxygen, right?
It's correct, true. Because you're exercising it, you're working it, you have a decrease of this stuff.
Okay, thank you.
Since it's active, you have an increase in these metabolites. Do we have to memorize these graphs too? You don't have to, I don't want to tell you not to memorize it, because you should understand it right now. It's going normal because it's in a normal state. Once it got started exercising or it got activated, you gave it more blood. Once it's no longer active, you took away the extra blood. Okay, let me show you the other graph and you'll understand how you don't really need to memorize it. So the other one, reactive hyperemia. It's reacting, okay? So what is it going to be reacting to? This time, it is going to be reacting to a sort, like for example, okay, let's take this situation. This blood vessel had a normal blood flow, okay? And then suddenly, for whatever reason, maybe there was an occlusion, maybe like similar to that route, we had a tie around the vessel, there was a decrease in the blood flow, okay? And then once the blood flow was reestablished, our body is going to react and, give it like as a compensation for whatever that happened, and it's going to give it like an extra period of high blood flow, which is a reactive hyperemia, okay? So it was normal, there was a decreased blood flow. Since it had a low blood flow at one point, we compensate it by giving it high blood flow for a period of time, and then it goes back to normal. Do you guys get it? Like, I don't want you to just memorize it. So active is since it's active, once it's active, we give it more blood flow. Reactive, it's reacting to this period of low blood flow by giving it more blood flow after it. More lactate, true, you guys, but you don't really need to worry about like the more specificities about it. Understand the concept of it, okay? So like active hyperemia is just that it's active, so we're giving it more blood flow. When we talk about like the metabolic theory, and lactate is going to be done, low glucose is going to be, okay, yeah, true, that does help you connect. So yes, these are all metabolites that are going to be released. I'll go back to the metabolite slides for you guys to see them again. So we got we got adenosine, which is the byproduct of ATPs. We got lactate, H plus, potassium, decreased oxygen, increased carbon dioxide, or even a decrease in the blood glucose. All of these will lead to your metabolic vasodilation, which can be seen in active hyperemia. And in reactive hyperemia, why exactly it happens is because, since you didn't give it blood flow for this period of time, since there was no blood flow, what happened is that the carbon dioxide or the waste products have built up, and when there was a blood flow again, they caused the vasodilation, and that's why it's a reactive hyperemia. Is it clear? This is all the slide. This is everything for you guys. Do you guys have any questions about the lecture?
I have one.
Yes.
Can I go back? What does he mean when blood flow is available again? When available, that part.
Right here? Yes, because we said it was normal here. Then for some reason, we had a loss of blood flow here. So as you can see, the blood flow is lower. And so when it starts to come back again, we give it as a gift, as an apology gift of extra blood.
Okay. Okay.
You get it?
Yes.
Okay. Any other questions, you guys?
I have a question about the
Yes.
baroreceptors.
Mhm.
So more firing by baroreceptors means more parasympathetic or sympathetic?
More firing, more parasympathetic, and it's an indication of more blood pressure. So take it like a 3 steps, okay? More blood pressure, more firing, more parasympathetic. Let me show it for you here 1 second. Oh wait, more mirror description. That's it. If you get this, خلاص, this is more than enough. Equal left PSNS. Is this part like it does even like more, and less, less. So everything is like together. Clear?
Yeah, got it. Yeah, thank you.
Can you please recap the entire metabolic and myogenic blood flow control briefly? Okay. So we said the metabolic theory, all it does is that there's too much metabolism, there's too much waste products, there's too little of our products that we need, such as oxygen. So what we do is that we vasodilate it, remove these waste products, and allow more stuff to come. Okay. So like if you have too much waste, too much garbage, you open it up to get it away and to get more of the healthy stuff through. So this is the metabolic theory. As simple as that. The myogenic theory, there's 2 parts. There's the nitric oxide, and then there's the muscles part. The nitric oxide is in the endothelium. Now, I did highlight here and change the color of shear stress because it's usually a keyword that is used in question sources and maybe in your exam. Like whenever you see shear stress, then here's most likely going to be a question related to an increased shear stress, and the answer will be some nitric oxide that will lead to some vasodilation. Okay? Or cyclic GMP, because nitric oxide acts through cyclic GMP. Now, the myogenic theory, what it says is that if there is nitric oxide, there will be vasodilation due to shear stress on the vessel. Muscles theory, the first one, what it says is that if there was like a sudden large blood flow through the vessel, which will like basically stretch on the vessel wall, the vessel will have a reflex of constricting, and then it will start to adapt. Okay, so it's normal, then it flows like that, it constricts, and then it starts to adapt to the different blood flow. Does that answer your question? Whenever sympathetic is activated, it is followed by vasoconstriction? Yes, because this is the function of the sympathetic nervous system. Whenever sympathetic is activated, it does its function of vasoconstricting, increasing heart rate, increasing contractility, And whenever the parasympathetic is activated, it will do its function of decreasing these. The heart decreases the heart rate, decreases contractility, vasodilates. So like, I never want to see any of you putting a question where there is an increase in sympathetic activity, and then you put vasodilation, because these two contradict each other. Even if you don't understand it, or if you don't understand what's happening, if you say increase in sympathetic, then it should be an increase in constriction and increase in heart activity. You can't have sympathetic with vasodilation. No problems. Right. So I did have a bunch of questions, but we have another lecture after this. So if you guys, I can give you like a break now, and I'll send you the questions with the PDF so that you can solve them alone, and send me the questions. Or if you have any questions about them later on my WhatsApp. The number is at the first slide, so that you guys can do the other lecture, because the other lecture has like an important graph, and inshallah Khalid will explain it for you guys. This graph, like, expect 2 questions from that graph in your exam. It's a really important graph.
Can I ask you
Okay.
questions now?
Yes.
Or
Wait, is myogenic always vasoconstriction? From what I found, from what we learned, from what was found in your slides, from what I researched, yeah, all I found was that it was vasoconstriction. At least for this one, for the myogenic reflex, because like the other one, which is like nitric oxide, it's vasodilation. What happens here is that since there is too much blood flow, it's just reflecting a reflex, so it's a reflex vasoconstriction. I'm gonna send the questions to you guys, inshallah, right after this lecture. Right when I'm done, I'm gonna send them to the host, and he's gonna send them to you guys. Right. So do you guys have any questions?
Can I ask my questions now?
Yes.
What does paracrine mean?
Paracrine means that they're communicating. It's just a method of communication between them. Like paracrine communicating, they're beside two cells beside each other. They're sending information to each other.
Okay. The last case about there's like 10 increase decrease cases. Just the last case, please.
Which one?
The slide that has increase decrease like 11 times. Or...
Yeah. 1 second. Wait. It's right there. Okay.
Yes, the last one. Just
the calcium by sarcoplasmic reticulum. Okay, so there is the sarcoplasmic reticulum inside the cardiac muscle cells. Okay, now what it does is that it takes the calcium and then hides it inside it. Okay, it hides the calcium inside. Now this is important when the muscle is contracting, because when the sarcoplasmic reticulum takes the calcium, hides it in, and then releases it out, and then takes it back and hides it in faster, there's going to be a faster heart rate. Because, you know, when you're taking up the calcium, are you starting a contraction or you're inhibiting the contraction when you hide the calcium?
Inhibiting contraction?
Exactly. When there is no calcium, you inhibit the contraction. So if the sarcoplasmic reticulum is acting fast, so imagine this, you're contracting fast, okay, you're contracting the muscle, and then you take the calcium, you inhibit the contraction immediately, and then you contract again, and then you inhibit it again, and then you contract it again, and inhibit it again. So if this is faster, that means you have a faster heart rate. But since we have already a high blood pressure, and since we activated the parasympathetic will cause a decrease in heart rate. And this decrease could be done by decreasing the slope here, and by decreasing the rate of sequestration of calcium by sarcoplasmic reticulum.
So I can understand it as a sequestration of calcium is related to relaxation, and we don't want that.
Mm-hmm. Why do we not want that? No. It's not that we don't want the relaxation. It's that if the sarcoplasmic reticulum is sequestering it faster, what this means is that the contraction will start and end very quickly, and then it can start another one faster this time. So if it starts and ends, for example, in 5 seconds, it will need this entire 5 seconds before it can start a second heart rate, right?
Yeah.
If it's contracting and if it doesn't slow down until 5 seconds, then you can't start another beat until 5 seconds have passed. However, if it's able to sequester it in 2 seconds, then every 2 seconds you can have a heartbeat.
Oh, okay.
You get it?
Do you have time for the last one?
Which one? Oh, what is your question?
The practice question about the proximal baroreceptor.
The
So,
practice question about the proximal baroreceptor?
yes, the tie question.
Oh, yeah. Let's see. Yes?
Yes, so فهمنا من proximal إنه هي للنص أكتر صح؟ فراح تكون وين الصورة تبعها؟
Yeah, wait, let me get the picture.
Oh.
Mhm.
Oh, so it's gonna be to the right, so it won't.
No, not that it's to the right or to the left. It's that it's closer to the center of the body. So it's, for example, whether it's here or it's here. It's closer to the center of the body.
Oh, okay. I got it. Okay, thanks a lot.
No problems. Right. Do you guys have any other questions? And I did go for you a bunch of practice questions at 10, but I don't want to take much of your time. So you can go through them on your own and let me know if you have any questions. And please scan this feedback QR code, and you can have like a 5-minute break before the next session. And sorry if I took much of your time. Good luck, you guys, on your exam.